in Cayman. No, you can't.
Good afternoon, everyone. I'm Brian Edwards, Chief of External Communications for the American College of Surgeons. It's my pleasure to welcome you this afternoon to our news briefing of surgeons involved in the Ukraine war effort. We have a fantastic panel for you this afternoon, and it's been certainly a highlight of the Clinical Congress this year. And so with that, I want to introduce Dr. Peggy Knudsen from the American College of Surgeons, and she's going to moderate our panel this afternoon. For questions, you can put your questions in the chat on this page here. You can also email your questions to pressinquiry@facs.org, and we'll get the questions answered as we get them in. So thank you very much. Looking forward to a great discussion this afternoon. Dr. Knudsen?
Thank you, Brian, and thank to all of you who are listening in to this press conference, and we look forward to your questions. My name is Dr. Peggy Knudsen, and I have the privilege of being the medical director for the partnership between the military health system and the American College of Surgeons that was started 8 years ago. One of the issues for us with this partnership is to learn from each other and to always be ready. And what does readiness mean? Well, if you're in the military, readiness means that you're ready to be deployed. But for civilians, we have to be ready as well to respond to mass casualties and disasters within our own country. So we thought it would be very important for us to learn about the kinds of injuries that were being seen in the Ukraine, and particularly to understand what the limitations and their challenges are during having to take care of patients while your hospital is being bombed, as we heard just earlier. So I'm pleased to introduce my panel. I'm going to have them each give their own introductions, and then we look forward to your questions. All of these people on the panel have been working in the Ukraine, so I'm sure you have lots of interest in what they're going to say.
Good afternoon. My name is Warren Dorlack. I'm a trauma critical care surgeon with the University of Colorado. I'm also the chair of the Regions Committees for the Committee on Trauma. I'm also the vice chair of the COT, the Committee on Trauma.
I'm John Holcomb. I'm a general and trauma surgeon from the University of Alabama, fellow of the American College of Surgeons, and I'm not on any committees.
Hello, I'm Hanat Harich. I am the surgeon from Ukraine, Lviv, Ukraine, the chief of surgery department, the biggest civilian hospital in the west of the Ukraine.
My name is Aaron Epstein. I'm the president of the Global Surgical and Medical Support Group, or GSMSG, that kind of facilitates getting high-end surgeons such as these gentlemen into conflict zones and austere areas. I also happen to be a fourth-year surgery resident at the University of Buffalo under Dr. Steven Schweitzberg.
Hi, I'm Steve Wolf at the University of Texas Medical Branch. I do burns, trauma, critical care, and have a lot of experience with military casualties from OEF and OIF in Iraq and Afghanistan when I ran the Army burn unit during that conflict.
I think we should start with you, Aaron. If you want to talk a little bit about your NGO and how you got organized and what you provide.
Sure, yeah. So in terms of the organization, so basically my background in defense kind of ended up being combined with my subsequent career in medicine. And really what we wanted to do was to provide a new service to populations in need. Everything I had seen in the Middle East previously would be aid groups that come in and do some surgeries and leave, or provide some supplies and leave, and there wasn't really a long-lasting impact, or it almost seemed like the purpose of what their intervening was and what they were doing was to maintain this reliance on another organization. So these poor populations were effectively eternally reliant on this outside support. And so in creating GSMSG, the goal is really to provide training and capacity building and really inherent drive towards self-obsolescence. The ultimate outcome for us is where the population that we're working with says, we don't need you anymore, and you can go. That's the best outcome for us, not something where they're saying, oh, we always need more supplies from you. And in that effort, we need the best trainers and skilled experts, like the guys on this, panel and the rest of the guys on our roster, because what they need to be providing is that high level of expertise. So we aim to bring the best of the best into these conflict zones and austere areas. And then the next thing is, well, if we're going to bring these guys and gals and this level of expertise, we need to keep them safe. That's been one issue that I think a lot of other groups that do have high quality and high functioning experts struggle with, is how do you bring people like this to these areas? And so, taking the the veteran population, folks, again, guys and girls from the special operations community, we can create essentially a cocoon around experts like this and bring them to the front lines where they have the biggest impact. And also, you look at these folks themselves, the physicians and surgeons and nurses and medics on our teams, most of them are paramilitary as well, so they're already inherently, mentally situated for these areas that we work. So that's really the makeup of the group, and again, the goal is to build capacities. Yeah, sorry, I was really kind of rambling there, but yeah, that's kind of what we do and who we are.
I'm going to send the next question to John. One of the things that was identified on the panel this morning, which was interesting, was the lack of a blood supply to treat some of the casualties and some of the innovative things. Those of you that don't know John well will know that he ran a large DoD-sponsored study that involved thousands of patients to figure out what was the best ratio for giving blood products. And then now we're completely switched over to something called whole blood. So maybe you'd like to explain that for us, John.
Yeah, I think leveraging what Aaron was saying, most of the folks who went over to Ukraine had prior military experience. Many of us retired military, and had just completed essentially 20 years of war in Iraq and Afghanistan. There are a lot of hard-won lessons in Iraq and Afghanistan. And when Colonel Lim called me up and said, retired Colonel Lim called up and said, hey, why don't you come over here to Ukraine and answer some of the questions that Hanat is asking. One of the things that we talked about very early on was resuscitation, how to optimally resuscitate patients. And the answer to that is from our experience in the war is with whole blood. So we talked about whole blood. I would say that in the civilian world, it takes 47 meetings in about 18 months to change over to whole blood. And Hanat and his colleagues in a time of war, when the Russians are invading their country, have an imperative to change, did it in 2 weeks. And so they switched and started using whole blood. And then with Hanat's influence through the mayor and the Minister of Health and the Secretary General of his 1,200-bed hospital, they now have a law that allows and propagates the use of whole blood, not only pre-hospital, but in the hospital across the entire country. Great congratulations to Hanat and for his team for leading that change across the whole country.
For Dr. Wolf down there, one of the things that you brought up was the delay in getting the burn patients to you. Those of us in the United States, we get our patients very quickly, rarely transported by train, which is what you explained as how many of the patients were getting to you, and the delay, which meant that all of those burns were basically infected. So maybe you could talk a little bit about that?
Yeah, so, the standard of care in the U.S. and most of the Western countries is really to get what we call early excision and graftings, usually within the first 48, 72 hours. In combat casualty situations, that's not always possible for a number of reasons that you can't really fix. And so what you get is these delayed wounds. We know with wound delays you're going to have issues with getting wounds closed. That's part of the problem, that there's the wound closure techniques, and there's some tricks that we hope to continue to teach and have the folks in Ukraine have some experience with. But that's not the end of the game in burns. They're going to have a bad scar. There's going to be a lot of functional problems. There's going to be a lot of cosmetic problems that we're going to have to deal with, and the earlier you deal with the wound itself, the less of those problems you have. And we know that from experience in the U.S. And the other thing I think is very important for everybody to know is it's not like you have a little scar on your abdomen this long. I mean, it may be half your body or more that is one big sheet of scar, and that's going to involve a lot of physiological changes are going to occur. They stabilize out about 1.5 years, but that's just the beginning of the game in burn care, is closing the burn wound. And there's a big game that goes on after that involves a lot of reconstruction, rehabilitation, and a big time team effort in managing these things. And as surgeons, we're kind of in the middle of that in that game, but there's a lot of other players that are involved as well.
Dr. Dorlack, you've leveraged quite a lot of the educational products from the American College of Surgeons. You talked about using the Stop the Bleed training. You took some Atom and Asset, I believe, some of the courses over, and now we have the new M curriculum, which as of today is got 12 modules that are translated into Ukraine, which you can take the next time you go over there. But maybe you could talk a little bit about how you were able to do, get the Stop the Bleed people over there to teach and the equipment that went with it.
Yeah, so I think we took very early on, we sort of took a multi-pronged approach at all of our educational offerings that we were going to try and do, and we weren't sure exactly what was going to work and what would be the best. So we kind of attacked it from a number of different fronts. So we were first started off by helping with translation of some of the DoD topics that would be pertinent, such as tactical combat casualty care. Some of those had been already translated by Aaron's group from the Global Surgical Medical Support Group. But working with the Department of Defense to try and get access to those to help facilitate translation, as well as some of our clinical practice guidelines from the Joint Trauma System. And so that was one of our first approaches. The other one was to do just lectures, and we started off doing those on Zoom with the help of a Philadelphia surgeon who speaks Ukrainian to do consecutive translation for us. We've subsequently have rolled that in partnering with the Kyiv Military Medical Academy to continue those, and that's being run entirely by them. So that kind of checks off one of Aaron's boxes at trying to get help them to take over. And so they're actually running those lectures. We still provide lecturers for it and content, but it's being run by Dr. Kurol from the Kyiv Military Medical Academy. And then those are done live across the country, hitting a number of their hospitals. So we did that as well. And then once on site, it was also a matter of looking to see what the needs were. So Kenji Inaba was one of our surgeons that was with our team. Kenji and Jory Klein, the two of them taught Stop the Bleed courses in a couple cities that we were involved with. In terms of materials, they actually had a lot of the materials there, but we had materials that came from Aaron's group, as well as materials that we had brought over individually. And then we also had training materials that were just used from in-country.
Dr. Harris, you gave us a good example of what it was like to provide care under fire. I think that got to all of us when you showed bombs going off really close to your hospital. You want to just elaborate a little bit more about that?
Yes, thank you. First, I want to thank for invitation me here. It's very important because we can make a good cooperation together. So war is very bad, but some things when the war happened started to go in faster, and these changes in the surgery of Ukraine society that we're doing now together, they are really very progressive and very fast. The the second thing, I want to thank this people, this sergeant who don't afraid to go to the Ukraine from their now peaceful lives and family from US to our country and help us to do a lot of good things that you already talking about. It's the whole blood, it's the ICU patient, post-trauma care, it's some really new tricks for us and from your Afghanistan and Iraq experience in the operation room, and it's also very important for us managing of the transportation, the patient from front line. So it's very big thing, very like I want to say like impressive example for a lot of sergeants from US, for a lot of people, how the man individually, the people can support the country who are fighting for their freedom. So I want to thank you. It's a big honor for Ukraine to take this help from you.
Thanks. Christina Frangu. I'm an independent journalist from Canada, and I write also for General Surgery News. Dr. Harich, I sort of wanted to follow up on that question and hear a little bit more about what it's like in your hospital for you now, day to day. It seems like, I think you said it's a 6,000-bed hospital. You have patients who must be in there for a long time and more coming every day. So could you speak a little bit about the day-to-day challenges of what your hospital is under right now?
Thank you for your question. We have 2,000 beds in our hospital, but it's the biggest hospital in Ukraine right now. The biggest challenges, the first when the war started, it was the massive hospitalization. We never had experience to have 100 patients with the injuries that need to go straight into the operation room. It was nobody from our doctors, maybe from all of the Ukraine, don't know how it works. The second thing that we have after the few days after the war start, we don't have the supplies. So our armed forces take all the bandage material to the front line, and some of days morning I am come to my department for work, and my nurses tell me that Dr. Harich, what we need to do because we don't have the material to make the bandage for the patient. Not only the patient with the injuries, but the patient with the general surgery disease like acute appendicitis, cholecystitis, and like that. The second wave, it was the problem with the drugs because the Russian forces, occupants, and the total evil, we call it in Ukraine like this, destroyed all the pharmacy factories in the Kharkiv region, so Ukraine have no possibility to do the pharmacy. And we have the period near maybe 2-3 weeks. After that period from Poland, we have the supply of already the drugs and some bandage material. So about this period, we tried to wash out material. We was feeling like we are on the maybe first or second World War, and it was a little bit difficult. But you know, I think that maybe true and good things exist in the world, because really this program and another, it's just one of a lot of things that happen good for us, for help us.
Just one comment, since you're from Canada. We actually did have Canadians with us as well, so they weren't all just from the United States. We also had Canadians with us as well, participating. So.
And then you talked about the operating room you have set up in the shelter of the hospital. How often are you using that?
We started to using that near 1 month ago, because 1 month ago we have very serious, massive rocket strike of the Ukraine and our city, and rockets goes nearby our hospital, so I make a decision to start operation in this shelter. In this shelter, personally, was the Dr. Holcomb, Dr. Warlock, was there, and also there was some. But in this shelter, we present our project about the rehabilitation center, and we meet there the patient, the American soldier, who have a amputation of both legs from the special forces, and Dr. J was there, and he operated this patient. So they meet in Ukraine in our shelter of our hospital.
John, you have something to say?
Yeah, I just, a little bit of an editorial comment, if I can. As a bunch of us are retired military, and there's been a lot of lethal aid sent into Ukraine by many Western countries, which is extraordinarily important and appropriate. The best way, from a healthcare perspective, the best way to prevent injuries is to supply lethal aid, and we're very supportive of that. I would suggest in this, and would be fun to discuss this, there needs to be non-lethal medical aid, not to the same amount as lethal, but you've heard from Hanat talking about supplies, equipment, drugs, because of the supply chain systems. You know, there are no airplanes. There's no FedEx and that kind of thing going into Ukraine anymore. 0 airplanes. It's all trains and trucks. And when you cross the border, the trains and trucks are lined up for miles. It's a huge problem. And I would make a plea to all of the Western governments now to supply substantial medical non-lethal aid to the Ukrainians for their civilians and military. Extraordinarily important that we help them do that.
I'm sure there are people that have questions online, so just tell me to stop when you... Go ahead. Okay. I'm interested to know, with the patients you're operating on a day-to-day basis, what's the sort of breakdown between people who are just coming with the regular things that need operating on, and what percentage of them are casualties related to the war?
About the transportation of the patient, yes?
Which ones are combat casualties and which ones are just regular trauma patients?
Yes. So our hospital before the war, we just work with the civilian injury, but I just describe you one last case that we have. The family, their father is fighting in Ukrainian forces in Donetsk, and his wife and 2 children was going from Donetsk is 1,200 kilometers with the backed roads because the Russia destroyed that on the east of the Ukraine, and they run by the car all of the day, and in our Lviv region they go to the car crash, and the mother, 2 daughters in the critical condition with the multi-organ injuries, and that's one of the example that the war also spreads a different, not only war casualty but the civilian casualty, but it's have some connection with the war. Mm-hmm. And a lot of these cases also, we're talking a lot about John and Warren about this, they also see this in Afghanistan when they work and see some burns of children, and it was not connected with the war, but because the parents was busy or something.
Yeah, I mean, these hospitals are busy hospitals anyway, so the other disease doesn't go away, and we have the same problem, you know, in the United States in our critical access hospitals that are essentially overrun, but they're not war casualties. But here they've got those regular patients that still need to be addressed. You have still patients with appendicitis and pneumonia and all those things. So those patients are still coming in, and this is just an additional burden upon them.
So, and I a little bit better understand the question. So before my visit the U.S., the last day there was 2 days before the airstrike near the hospital, and I ordered to stop the all elective operation because we're waiting for the emergency patient. And before the day I go out to the U.S., we have near 40 patients come here for the elective operation because they're waiting with the cancer, with the different diseases, and it's also the big problem now in Ukraine to manage this.
So one of the questions we got kind of builds a little bit on what you were saying, which was about the type of injuries that you were seeing and how that compares to what you were seeing in what we used to see in Iraq and Afghanistan. Can you talk a little bit about sort of how that is, how you're treating those types of injuries, and how the U.S. surgeons are learning from that?
Yeah, it's, you know, we've thought about this, the type of injuries, are they different in this war than Iraq and Afghanistan? And you almost have to be a student of military history a little bit and go back to World War I where really the munitions that are used are extraordinarily the same. They may be delivered a little bit differently, but certainly the human body obviously hasn't changed in the last 100 years. The munitions haven't changed much in the last 100 years. So in my opinion, which is limited to what we saw in one little area, I don't see much different from these wounds than what we saw in Iraq and Afghanistan. Now, there was a question about military versus civilian. The military guys are largely wearing very, very good personal protective gear, helmets, body armor, et cetera, and the civilians obviously aren't. And so the civilians have the same injury pattern that we saw in Iraq and Afghanistan as well, where 80% of the casualties that we all took care of, you know, over 20 years, up to 80% were civilians. And so Hanat is seeing military casualties, but more civilian casualties of war. One difference probably would be the collapse of buildings based upon the Russians shelling civilian installations and hospitals and collapsing buildings on purpose, by the way, as a strategy. And then you see the crush injuries and compartment syndromes and being crushed in building collapse. That is different. We saw a little bit of that in Afghanistan and in Iraq, but not to the extent that these guys are seeing now.
So there was, I will, for the burns, it seems that there wasn't a whole lot of IED stuff, and which was what we saw a lot of from Iraq and Afghanistan. As far as the combat casualties, the civilians are the same, but it seemed a lot more penetrating blast kind of stuff instead of IEDs, which is basically vehicles that had blown up around them, basically.
Yeah, but I think the point that John made is totally valid. I mean, these are, whether it's an artillery shell from 1919 or it's an artillery shell from, 1945, or it's an artillery shell that is delivered in 2025, it's still an explosion. There's still fragments, and they still cause devastating wounds.
Great. We have a question about what roles are the aid groups like the ICRC and Doctors Without Borders playing in medical aid?
Yeah, I think several of us can answer that. I'll answer the question first, and then Aaron can answer. The NGOs, all of the NGOs, all of them are doing extraordinary work and important work. And it was my first experience with an NGO. Aaron and I have talked about that. I last deployed in 2006. I retired in 2008, and now I went over with an NGO. Extraordinary opportunity to help people. But the NGOs all kind of operate in different spheres and do a little bit of different things. The Ukrainian colleagues that I've asked, what do they think about the NGOs? I've asked that question, at dinner, later in the afternoon or evening. And for the majority of the NGOs, they've been extremely well received by the Ukrainian colleagues and doing extraordinary work. I would say that some don't. But that's human nature, right? That's what you see everywhere around the world, whether you're in the military or not. Aaron, your thoughts on that?
Yeah, so I agree with John that every group has their niche area, and groups that have massive funding that come from like ICRC or Doctors Without Borders and have a capability to sustain massive logistics and can bring in literal tons of supplies. I think that they've done an exceptionally good job at that. Our group, because we focus more on the human capital and the expertise such as these guys, our niche area is really that training and building capacities, and I would like to believe that we've done a very good job of that, and I'd say we have a track record of doing that around the world in conflict areas. in this, and in the same way that we would not excel in bringing in literal tons of supplies, I'd say other groups would probably have a difficult time excelling in bringing in that human capital piece. So I agree that every group is trying to do their thing, and yeah, most of them do a decent job, and some don't, and you know that's up to the recipients to really kind of dictate who's doing a good job and whatnot. But I would say for us in particular, bringing the human capital to really focus on building capacities. You know, we stay in our lane, and that's what we do. So that's all I'll really say about that.
I would also say that this organization was very useful for us and easy for work with. I explained why. Some slides I put in my presentation because it's very easy to work with. After the few minutes, the first surgery team come to our hospital, maybe 10 minutes we already working in the ICU department, examine the patient, working in the operation room. Also, we didn't speak about this, but we have a lot of not only like medical supply, bandage materials, drugs and like this, but we have also the supply of very important for us, it's the anesthesiology, machine for transportation the patient, it's the blood heater that we didn't have in the hospital, and now it saved already a lot of lives. We use this. So our colleagues from US come to our hospital, we speak, they after the 1-2 days see our problems, and it was very easy to take this all stuff to Ukraine. Also was very easy to have some new specialists from different kind of medicine. Like we see that we have problem with the post-operative nursing. We ask them to take. We take the nurses. We see the problem with in the burn department. We also have the burn doctors, and it was a lot. So it was easy to communicate and to have help.
So just to tag on a little bit there, we had a multidisciplinary team that we took over. And again, we tried to decide on the team members based on what their experiences were, especially making sure that we had the right balance of prior military to help with some of the things that may be more consistent with being in a combat zone. But we also planned on having a multidisciplinary team that could function based on the needs that we initially identified. When it came, and so we had trauma critical care, trauma orthopedic surgery, burn surgery, trauma critical care nursing. That was part of this. We had one team member that was a neurosurgeon that we sent out just to sort of investigate that. But I think one of the things that other thing I wanted to hit on was there were a number of NGOs, or a number of teams working in country, and we really tried to coordinate with some of those other teams. When it came to education, for instance, there was a team led by Sean Kivlahan from Brigham and Women's in Boston, and he was with another NGO, and they were teaching ATLS. And so they were going around the country teaching ATLS. So we know, all right, hey, we got that box checked. That's not something we need to work on. Mm-hmm. Aaron's group had already been doing tactical combat casualty care. So we can. There's definitely some support that we can try and bring to that. So we again focused on Stop the Bleed. We focused on the asset course and some other things. But again, trying to coordinate from an education standpoint, also trying to coordinate with the other surgeons. So we knew that there was a British team that was going to have some heavy reconstructive guys. Team members, and so we didn't need to send a big reconstructive person because we could tag on with those. And so we partnered with them on operations that would require that multidisciplinary approach.
Just real briefly, you mentioned ATLS. For those who are watching who don't know what that stands for, can you just explain ATLS real briefly?
It's one of the Committee on Trauma's sort of flagship courses, and that's the Advanced Trauma Life Support course. It's also paired with a pre-hospital course that's done by NAEMT, which is pre-hospital trauma life support. And so those courses ATLS had really not been propagated too well across the country. PHTLS has been there since 2014. I believe Aaron's group had been involved in some PHTLS courses, and again, the Tactical Combat Casualty Care part. The ASSET course is, again, another American College of Surgeons course, and this is a cadaver-based exposure course. And one of our instructors, or one of our team members that was over there, put that on with the Knott's group.
There was a follow-up on the supply question. Dr. Hulkman, you mentioned sort of logistical challenges, and Dr. Hanat, a little bit about sort of, supplies in general. Are there enough supplies, or is there supply shortages that you're seeing across the country?
There are extraordinary supply issues across the country. To me, this is the reason I wanted to bring this up, and I appreciate the following question. I think it's an imperative. Right, the Western countries, NATO, et cetera, are supplying billions, and we all know this number, 50, 60, $80 billion of lethal aid, and I think we all strongly support that, right? That's a good thing. There needs to be some billions of non-lethal aid to balance out a little bit the lethal, so that when the Ukrainians and the Russians get injured, that they can be cared for in the way that we all want to care for civilian and military, irrespective of who they are, because that's what we all do, with supplies and drugs and instruments that are available to restore those injured back to their level of functioning beforehand. And it is a problem right now that I think is an opportunity to help improve and care for those casualties, both military and civilian, in Ukraine.
Can I just add a follow-on to that and ask if there's things in particular that are in short supply?
Everything.
Okay.
I mean, it's truly.
Antibiotics, suture, negative pressure wound therapy devices.
External fixators. I mean, it's interesting, and Hanat needs to answer this question as well, but one of the things that we're able to do is to step back a little bit and look kind of strategically, if you will, right? You can get very caught up in the tactics of a single patient, but if you step back and think about a system of care, which is what we all learned how to do in the military for over 20 years. I mean, there's several hundred years of military experience here in this room. Is you have to step back and think strategically, and wars are won with logistics, right? We all know that. And on the medical side, you need everything. Everything. You need monitors, you need blood warmers, you need, blood bags. There's a shortage of blood bags. We've been trying to get blood bags into Ukraine right now, and it's really hard to do because somewhat appropriately, all of the stuff going in is lethal aid. And again, I'm not saying stop that. I'm just saying add $1 billion or $2 billion, right? 1 or 2% of non-lethal aid. And we know how to do this. We did it. We put all of these supplies in Iraq and Afghanistan for 20 years. All you got to do is say, send a combat support hospital. Check. Right? And, send 10 of them scattered around the country. And it's got all the equipment, the operating lights, the sutures, the knives, the blades, the things that you need to take care of these kind of wounds. It would be an extraordinarily important augmentee to the personnel. You have all sorts of personnel, but if you don't have the stuff, you can't take care of patients. Yeah, Hannah?
Yes, it's a very good comment and true, because when in the country where is no war, maybe like US and different countries who support Ukraine, at the start of the war, it was in all news, BBC, CNN, every day, and the people are boring from that when it's going. So it's normal that when the war going long, the people start a little bit boring, no news, and thinking that everything may be stable there. But we have not like a standard supply every time, and we have a lot of discussion, because for us it's like very interesting discussion, because some colleagues from US surgeons come to our hospital and they don't understand why for 5 patients we can use with the wounds negative pressure system, and for 5 I can use, because I know that I have 20 system and I need take the most difficult patient and treat them modern, and patients who are left need to be treated like a 30 years ago methodics. So it's really true. If we can have such supply, if we put the button and say what we need, it's come, it's very good. But also Warren can tell you about that he first time maybe in his life see the needle that was used 40 years ago maybe. But because we have no supply, sometimes we need to use needle that need to be sterilized, that was used a lot of years ago. And before the war, do you understand that we do modern operation? We have Da Vinci robot in our clinic, the first series, but the war changed everything and like that.
I think it's important to also note when we're talking about supplies, you need a lot of them. This stuff turns over very quickly, very fast. And to do wound care on somebody in a burn wound that's going to take a month and you have to change them every day, and I need a whole case of Kerlix or whatever gauze for every day for that patient. And so you can run things out very quickly. And so these supply issues have got to, that's what, and then the other thing I was going to mention about that is it can be even worse than that. Because if you don't do the wound care, then now they start growing these organisms, and now you've got an infection control problem. Now it runs out of control because you don't have the supplies to do just routine, standard, run-of-the-mill care. And that's enough to pile on what John was saying. Hey, you've got to get all the other stuff in. When in our experience in the military, you go to cash. Yeah, all that was part of the game, and there were 200 people in the supply chain that were making sure that we had gauze, and that's not happening.
Yeah, I think that supply issue has been really one of the sort of lead causes of the wound infection rate. I mean, and then if you get an infection in one patient and they're in the same room, now at the end of the day, everybody else in that room has it. So if you can't do the basic stuff, which is right now a problem, if you can't do the basic stuff, it's going to be way more difficult and be a much bigger problem in the end. And we're seeing that.
Great. Christine, any final questions?
Yeah. I was struck by what you said about the need for a rehabilitation center long term. And when I've heard the rest of the panelists talk in the past about military care, getting people home and then getting them into rehab very quickly is essential. What is happening to your patients now when they're being discharged from hospital with these kinds of injuries? Where are they going?
Thank you for this question. It's a very, very big problem for Ukraine because Ukraine never had like the National Rehabilitation Center. We had maybe few factories that work with the orthesis and like this. And after the war started, we have 100 now and maybe 1,000 patients that need rehabilitation, that need prosthesis, that need reconstructive operation, that need reconstructive orthopedic operation, that need mental health help and support. That's why we make such initiative to build in our city because maybe in that day it's the most safety city in Ukraine, this rehabilitation center where we can do make the orthesis, prosthesis and another this all stuff that they're talking about. We make this project. In the internet you can find this word Unbroken Ukraine, and there is all information about that, about our plan and about the donation. Now, this day we don't have the building already finished, but we integrate this center in our hospital. So we take on the work more rehabilitologists, physiatrics. We start to do reconstructive surgery already, and we prepare to do this right now because we don't have a time to wait. And if this program and project will be realized, we will our specialists will just move in the normal condition, normal special building to do this.
Yeah, there's a lot of these patients who have complex rehabilitation problems or severe burns are being sent across Europe. Europe has really opened their arms in hospitals to care for these very complicated patients. I think the last number I heard was over 1,000 have left Ukraine now. And that's great, but they get, the nuclear family in Ukraine is very strong. In the picture I showed of the burn patient with their family with them in Finland. So they go with their families, or if they don't leave their families, then it disrupts that nuclear family bond. So this idea, and let me just step back and say in the U.S. military, we had the same problem. We recognized the problem, but it took years to start building these rehabilitation centers that were on military compounds.
Center for the Intrepid.
Center for the Intrepid, yeah. Wow.
From the non-military person.
Yeah, there you go. It took years for us to build these, and Ukraine has recognized this need. And, 4 months into the war, has launched a huge effort. If anybody wants to do anything, they could donate to the Unbroken, which is on the website, and donate to help build that facility in Lviv to keep the Ukrainian casualties there, military and civilian, with their families in Ukraine, which is we all strongly support.
Can you tell us about the Unbroken? That's the first I've heard of it.
So talk a little bit about Unbroken.
Maybe John talk because you're an ambassador of this.
Yeah, so
yes? Right.
actually, J.J. Hammond and I were there on the sort of unveiling of of their project. But it is the goal is to develop a very similar facility like we have with our U.S. military rehabilitation facilities, and that is the first would be built in Lviv. Right next to the Lviv Emergency Hospital. And this would be a place for patients with injuries such as amputations or patients needing really more complex reconstructive surgery. But all those patients need an enormous amount of physical therapy, occupational therapy. And so to start to build that infrastructure is what they've got in place. They launched a massive multi-national effort and have a lot of support from Germany, from Switzerland, United Kingdom, other places to try and help them with that project. So they've got a really good start, and we just want to try and help them get across the finish line.
Thank you.
Yeah, so what I'm going to take away from this is that we should be supporting this rehab center, and we should be supporting supply chain, right?
Non-lethal.
Non-lethal.
Yeah,
Non-lethal aid,
Thanks.
correct? Is that the way to say it?
that is.
Okay, no more questions? We all set? All right, thank you so much for your
Thanks.
interest, and really a great panel.
I brought out the prop. I brought out the prop. I had the prop.